Hello everyone, we are in Helsinki and with me is David Tuller, a doctor of public health and an accomplished journalist. David, thank you so much for traveling all the way up here and joining me for this interview.
Thank you very much.
Now you just finished giving a speech on the PACE trial, which is a study on some treatments for ME/CFS, also known as chronic fatigue syndrome. Why travel around the world and talk about just one study?
So the PACE trial was presented, created and done as the, quote, definitive trial of the two treatments that have essentially been the standard of care, cognitive behavior therapy and graded exercise therapy. It's by far the largest, most expensive, and a study of these treatments. And so basically, it's important to focus on it because it's such a bad piece of research, and it was cited everywhere in justification of these treatments. So basically, debunking it has been something that seems essential in order to improve the treatments that are available to patients.
Okay, so it was bad science. What if someone wants to fact-check this, that it's bad science? Where to go? Where to read?
You can read any of my blog posts about the PACE trial. They're all listed on Virology blog. There's an ME/CFS page on Virology blog where all the articles are listed. You can also look at I've orchestrated several open letters signed by many distinguished researchers and doctors, one to the Lancet, several to the Lancet, a couple of versions, one to the journal Psychological Medicine. Those also outline some of the major flaws of the study as I see them and as the signatories see them.
So it is not a matter of different schools, so to speak, or opinions. It is science fraud.
Well, I'm not going to use the word fraud.
Okay.
That's, proving fraud is very complicated. All I'm just documenting is that they violated multiple methodological principles of scientific investigation, such as the fact that no one can be, quote, recovered and, quote, disabled simultaneously on one of the measures that you're using in your trial. This is a very odd situation where people in this trial could theoretically get worse for physical function and still be found to have been, quote, recovered or improved at the end of the study. That's just ridiculous.
Right.
And I checked with my colleagues who are biostatisticians and epidemiologists at Berkeley and elsewhere. Everybody was shocked at the poor quality of the study. Nobody could understand how the Lancet or other journals could have published the results. The whole thing is so ridiculous. And why it's survived, I don't understand it. I attribute it to a certain degree to the fact that it was produced by distinguished researchers with eminent careers and at eminent institutions in the UK, and it was published by eminent journals. And there is apparently such a culture of deference, as far as I can tell, in the UK towards people with degrees and high-placed individuals that when you challenge them and say things they don't like, they accuse you of harassment and libel. So that's really not a proper way for science to proceed. Science depends on open and vigorous debate, and sometimes that debate is very unpleasant for the people whose work is being discussed. If they didn't expect that, then they shouldn't have published any research at all. All I've done is challenge their research. I haven't harassed them, I haven't libeled them, but that's their only defense. They can't really justify what they did. If they could, I couldn't have gotten 100 plus people to sign my letters.
Tell me again, what is the principle behind this psychosocial model or the belief?
So as I understand it, this originated about 30 years ago. They posited that basically patients might have an initial infection that triggers, that they get sick from. Then they are already recovered from that particular infection, but they think they still have an organic illness. One of the reasons they think they still have an organic illness is that there are lots of ME activists running around, or they might join an ME group, which is persuading them that they still have an organic illness. Then they spend a lot of time in bed resting because they think they have an illness and they feel bad if they do something. And they feel bad if they do something by this theory only because they're deconditioned. But they think it's because they have an ongoing illness that is going to make them sick if they do something, so they go back to bed, and then they get worse and worse, and they get into what they call a vicious downward cycle of deconditioning, then sleep dysfunction, muscle atrophy, disrupting their sleep rhythms and all that, and they posit that there's this cycle, and that all you need to do, or what you need to do to sort of jumpstart people out of it, is to give them graded exercise therapy so they understand that they can improve, or you want to give them a form of cognitive behavior therapy, not like the cognitive behavior therapy one would get for cancer or for any major illness that's recognized, but a specific form that's designed to alleviate you of so-called unhelpful beliefs or dysfunctional cognitions about the condition that you have. In other words, you think you have an organic illness, you really don't. We know better. We're going to sort of convince you that you can get back to your regular life, and if you don't get back to your regular life, it's because you don't really want to and you're not trying hard enough. That's the basis of the theory that they've proposed. Now, I think they've recognized right by now that this is really ridiculous. I'm presuming that they have. They seem to be sort of always softening, making adjustments a little bit to what they claimed, but that's the basis of the theory.
Right. By any standards, if any study on any illness claims that, what was the initial claim, that over 50% improve, 22% heal, 60%, that would be a miracle cure for an illness this severe, and they claim that the initial claims were such.
Right. So basically, in the first paper, the Lancet paper, they claimed that about 60% improved from these treatments, and of course that was a completely different definition of improved than the original one that they proposed and promised in the protocol, which is what researchers write before they get approval for a trial. When you write a protocol, you explain everything that you're going to do, you explain all the outcomes that you're going to have, and how you're going to analyze the data. So the improvement rates that they reported in the Lancet paper were very different from the improvement definition that they used in their protocol. Similarly, with recovery, they published a paper on recovery in 2013, 2 years later. The definitions that they used, they had 4 criteria for recovery. Every single one was dramatically weakened between what they wrote in their protocol that they would do and by the time they published the paper. So when they published the paper, they did find 22% recovery. Now, of course, if you had a pill for cancer that cured 22% of cases, everybody would be ecstatic. For HIV, my God, how many years have we had no cure for HIV? So that would be great. However, when you reanalyze the data according to their original promise and on the basis of which they received funding and approvals to do the study, you find, and I was part of a paper that found this, that the rates of recovery, none of the 4 groups were above 7%. The rates of recovery, as defined, were not above 7%, and that in none of the groups were statistically significant from the others. So basically, nobody recovered from the treatments per their original definition. Since they weakened all the criteria, of course they were able to come up with a 22% figure. That isn't surprising. If you weaken your outcome measures, you're going to come up with results that look better when you publish them. That's just not science to do that. They did that after the fact with no committee, with no apparent approval from their oversight committees. They just decided after the fact, well, as they've said, we found that our original measures were too stringent. So they decided to change them. That's not science. You can't do that after the fact.
I believe in Norway you mentioned after the speech that the Lancet at around the same time had another study that was bad science about vaccinations and autism. Did this have? Do you know if that had an effect on the retraction of this article?
Okay, so that study was a 1998 study. It was not published at the same time. It was about, I guess, 10 or 13 years earlier than the first PACE paper. That was the famous study by Andrew Wakefield, a doctor, which purported to show that there was an association or a link that vaccines caused autism. The Lancet, after a lot of uproar and a worldwide anti-vaccine movement, the Lancet retracted that paper. I forgot what year. But in any event, it was the same editor, Richard Horton, who's the current editor, who both published and then retracted that paper. So I have no knowledge if that played a role. I do know that it's embarrassing for an editor to publish a high-profile paper and then have to retract it. So one of the points with the Lancet paper is that there were several analyses of the data. I don't presume that all of those analyses require retraction, but that particular analysis needs to be retracted and has to be removed from the paper. So the paper might have to undergo a massive correction. It doesn't mean that the findings are good or that it was good science, but you need more than just bad science to warrant retraction. Because basically, you can do bad science, but if it fits within the current understanding of what's allowed, then it's not, it shouldn't be retracted, or it can't be retracted. For example, all of these studies of cognitive behavior therapy and graded exercise therapy have a fundamental design flaw, which is that they're unblinded trials so that both the patients and the researchers know who's getting in which treatment arm, and they rely on subjective self-reported measures of fatigue and physical function or other measures for their reports of success. That's a recipe for enormous amount of bias, an enormous amount of bias that you can't possibly tease out. You have no idea how much bias is induced by the fact that people know what they're getting, they know the treatments that are supposed to work. So if you ask them at the end, did they work, and all you're getting is, yes, they worked, and you have no other evidence from objective findings that they worked, that's not really evidence. It's just we have no idea how to interpret that. And so since all the studies based on this paradigm have that feature, it's really not acceptable to make public health policy or medical guidelines or clinical recommendations based on that. The fact is that in PACE they had 4 objective measures. All 4 of them failed to support the objective findings. An actual honest scientist or someone with integrity would have said, hey, our objective findings seem to not support our subjective findings. We better think about that. What does that mean? No, that's not what they did. They basically ignored and dismissed objective findings that they had produced and basically said, well, we're going to just believe in our subjective findings, and for this or that reason, we don't really think our objective findings, warrant any kind of much consideration.
Right. Finland is still sort of taking baby steps with the treatment of ME/CFS. The patients don't get treatments and hardly a diagnosis. And we have a chance to go the right way from the beginning. What would you say to any healthcare professionals that are watching this, what to do?
So, from my talking to a lot of patients, and from what I know of talking to clinicians in the U.S., the best thing doctors can do is, one, believe the patients, believe that believe them. If they say they can't do more, they probably can't do more. They're not malingering, they're not lazy, it's not that they're not trying. Of course, everybody wants to do more. The idea that millions of people around the world are getting some secondary sick roll benefit from spending their lives in bed is just, ridiculous. Nobody wants to spend their life in bed. Maybe one in, 25,000 or 100,000 people does, but really most normal people do not want to spend their lives in bed. Now, of course, people can have all sorts of reasons for fatigue. But the clinicians who actually are trusted by patients and seem to have the best results are those who are not pretending that they're going to cure the patient. They're basically dealing with symptom management. So they're looking at the various symptoms of this illness, and sleep disorders and cognitive dysfunction and POTS or orthostatic intolerance, and they're trying to deal with each one individually and seeing if they can get them under control. Until we have actual treatments for the underlying illness, whatever it turns out to be, or whatever the physiological mechanisms turn out to be, that's about, what doctors can do. There is a test, which is a 2-day exercise test, which some people in the U.S. will get to prove that they're disabled for purposes of disability. The problem is that it really, the way it's been done mostly, requires people to push themselves into a relapse or into what they call post-exertional malaise. And so basically you're asking patients, or basically to do the test, you're requiring patients to do harm to themselves. And most patients won't want to do that, and doctors don't want to ask patients to do that. There's ethical issues. Some patients have to do it or feel they have to do it because they want to get disability benefits, and it's one way to document physiological dysfunction. But there isn't what we really need, which is some sort of blood test or some sort of other way of physiologically what is going on in the body.
Thank you so much for this interview, and I hope you enjoyed your visit in Finland. Thank you.